All right, let's go ahead and begin. So good morning. Welcome to today's Prevention Subcommittee meeting. Give me 1 second. Let's go ahead and proceed with roll call.
All right. Sorry, I'm working on my laptop today, so I just have one tiny screen. Okay. Senator Doniate.
Here.
Debbie Nadler. Eric Schoen.
Present. I'm here until 10 o'clock this morning as a reminder.
Great. Thank you. Jessica Johnson.
Present.
Senator Severs-Gansert.
Here.
All right, Mr. Chair, we have a quorum.
Thank you so much. Let's go ahead and proceed with public comment. Public comment will be received via the Zoom meeting, so it should be limited to 3 minutes per person. No action will be taken upon a matter raised during this period devoted to comment by the general public until the matter itself has been specifically included on the agenda. So, of course, just a reminder, please wait until I recognize you. So if there's anyone that would like to provide public comment this time, if you want to go ahead and either raise your hand or you can go ahead and unmute yourself.
I'm not seeing anybody so far with a raised hand. I'll give it another moment.
I don't seem to see any. So let's go ahead and close public comment for now. Again, if anyone wants to comment, we have another one at the end of this meeting. We'll move on to the next agenda item, which is to review and approve the minutes from the July 28th, 22nd Prevention Subcommittee meeting. Members, are there any questions or changes or corrections that should be made? Seeing none, I'll go ahead and take a motion to approve from any of the committee members. Raise your hand if you want a motion. We got a motion from Senator Gansert and then a second from Ms. Johnson. Any questions? All right, let's go ahead and all those in favor, please say aye or raise your hand. Looks like everyone's unanimous. Any opposed? Any abstentions? All right, motion carries with everyone in unanimous support. Let's go ahead and move on to our next agenda item, which is a presentation on overdose prevention and harm reduction services in Maryland. Today we have Ms. Erin Russell, who is the chief for the Center of Harm Reduction Services from the Maryland Department of Health, Prevention and Health Promotion Administration. So please proceed when you are ready.
Great. So Erin just emailed me. She's having trouble logging on. If I can just stop sharing my screen. Oh, she is here. Erin. Great.
Hi.
Just in time.
Yeah, perfect timing. And I do have slides, so as soon as I'm able to share, I'll get those rolling.
Great. Let me stop sharing.
All right, go into presentation mode. And can you remind me how much time I have?
We were thinking about 10 minutes, if that works.
Okay, great. Thank you. All right. So again, thank you so much for having me. My name is Erin Russell. I serve as the chief of the Center for Harm Reduction Services with the Maryland Department of Health. We're housed within the Infectious Disease Bureau. And if time allows, I'll highlight what's unique about that in the context of naloxone distribution in Maryland and the STOP Act of 2022. But the center's been around for about 3 years. I myself have worked at the department for 8 or 9 years. This is my 9th year, and I've only ever worked on the overdose crisis, and I've been involved in harm reduction specifically since 2008. So it's a long-time passion of mine, and I'm always happy to come and talk about it. I could talk all day, so I will try to keep it to 10 minutes. All right, so what I'm specifically talking about, or the main bulk of this presentation, is the STOP Act. And so the Maryland General Assembly passed what was branded as the STOP Act of 2022, stands for Statewide Targeted Overdose Prevention. And the core of that act is the creation of a new naloxone mandate. This is one of the first community-based naloxone mandates in the country. And what I hope you take away from this presentation is that this bill and this mandate is extremely data-driven, that we've looked at what is causing overdose, who it's affecting most in our state, and then what the barriers are for them to get access to naloxone. And that the timing was right to take a public policy approach and actually mandate it. And then finally, we have the infrastructure in Maryland to do something like this and to actually see it through. And the Center for Harm Reduction Services will be ensuring the implementation of this law. So the center, again, was created just a few years ago, but it is really essentially the backbone of harm reduction programs in Maryland. We provide the policy support. We implement programs in accordance with state law, and we provide funding and technical assistance to programs on the ground in Maryland so that they can best serve people who are actively using drugs. Our goal is to get as many people who use drugs and who are at highest risk of overdose and infectious disease connection, have someone checking in with them once in a while, and then have them be connected to resources as they need them. And so that's our mission. Whether or not people get into treatment, that's an option for them, and we facilitate that for many people, but it's not the end goal. Our primary goal is to connect with people and have a system that's responsive to their needs. So in the context of the STOP Act, the center purchases all the naloxone in the state of Maryland. We have over 160 local sites that offer naloxone in the community. And so we do what we call a centralized purchasing model, where we buy the naloxone and have it be shipped directly to them. All right, so a few goals of the STOP Act that were accomplished, or that we hope to accomplish, are first, to get more naloxone in people's hands. Like I mentioned, there's not enough naloxone across the state of Maryland, even though we have a pretty robust naloxone distribution system. I mean, I mentioned 160 local programs are handing it out. We have sufficient funding to buy as much naloxone as these programs want to give out, but we're still not meeting the mark. We're still not getting enough naloxone out there to actually have an impact on overdose mortality. And there's a couple recent studies that have looked at exactly what that number should be. And Maryland needs to double the amount of naloxone we're giving out in order to achieve that. So this was really a time when we were like, we've spent 8 years now asking people to hand out naloxone. It's really time. All these providers should be doing it. And if they're not doing it by now, we need to mandate it, unfortunately. So it was this time. Second, we want all these other providers, and I'll go over this list of providers in a moment. We want them all to take ownership of the naloxone distribution. That it's not just the health department or harm reduction coming in, doing a training and leaving, but that it's actually in the workflow of hospitals. When someone leaves, they have the naloxone on site. The nurses or peer recovery specialists on site know what it is and how to give it out. Same thing with a homeless shelter, that they're not relying again on a partnership with a harm reduction group to come in and do the training, but they've got the naloxone on site. They're tracking how much is going out and taking, having ownership of it again. We think we've seen that to be a more sustainable model. Finally, we wanted to put this in state law so that it would help encourage a budget allocation for naloxone. We rely on federal funding, as most states do, and this did accomplish the governor including a supplemental budget award for naloxone in our state budget. Finally, we can talk about naloxone, but it opens the door for other education and initiatives. So we provide a lot of training and technical support, and so we hope to extend that to these new providers, bring them into the harm reduction fold, I guess, or help provide education they need. All right, so I know I'm talking really fast. There's a lot to say. I've already mentioned saturation, that there hasn't been enough distribution. The only other thing I haven't probably emphasized is the high risk individuals. And that also builds on just a lot of data analysis that has been done in Maryland. The DORM project is a data matching project where they're aligning information about someone's interaction with criminal justice, with hospitals, experience of past overdose, with death data. So looking at the trends leading up to someone's overdose death. And so that really informed where we need to be targeting naloxone. Okay, so I'll explain the STOP Act in 5 parts. First, EMS providers. So the STOP Act added language in EMS statute that allows an EMS provider to leave naloxone behind after an overdose. As you know, providers can treat. They've been delegated authority to treat an overdose, but they don't have dispensing authority. So this means that they're totally covered if they want to give a naloxone kit for someone to keep for later use. And we have some of these leave behind programs in Maryland. We hope to see an expansion. I know there's some in Nevada that you all have been early adopters of that model. All right, the second part is the mandate. So the mandate affects homeless services programs, intensive outpatient programs, opioid treatment programs, state and local correctional facilities, and the Division of Parole and Probation. All of these providers, I call them, have to have a protocol that includes the offering of naloxone to people with an opioid use disorder, people who receive services from them, or people who are at risk of a drug overdose. The only other difference in here is the implementation timeline. So homeless services programs have until 2024. IOPs and OTPs have to be in compliance with this by June 30 of 2023. Correctional facilities and parole and probation also have until 2024. This mandate's in effect as long as the department pays for the naloxone and gives the naloxone to these providers. So they don't have to find funding within their own agencies for it. We'll keep purchasing it and make sure it's available to them. And as long as we do give it to them, they're mandated to give it out. That was the thing that helped allow us to have a budget line item for it. So it serves a couple purposes, that it's not an unfunded mandate in some ways, at least in the covering of the cost of naloxone, and it compels the department to keep paying for the naloxone. The Secretary of the Department of Health may adopt regulations. So the Center for Harm Reduction is writing regulations right now, which really the regulations will just say that all these providers have to submit forms to us to order the naloxone. It's really just about the logistics of ordering it and how they're going to track it. Okay, another component of the STOP Act affected our existing naloxone distribution law. And the most important thing on this slide is that it added protections for businesses. We heard from businesses that they're hesitant to stock naloxone or give it to their staff because of liability concerns. So now this law covers businesses, and that a cause of action can't be taken against them if they, in good faith, make naloxone available on their business premises. The other change is just from naloxone to opioid overdose reversal drug approved by the FDA. And that is because of the lobbying of Opiant, a pharmaceutical company that's going to be releasing an opioid overdose reversal drug soon. And so they wanted, it's not naloxone, but it reverses overdoses. So they wanted to make sure that it was included in our state laws. I think they're doing that state by state. So if they haven't been in Nevada yet, they will soon. Okay, last is hospitals. Same thing. And the reason this is in part 5 and not part 2 is because there was already a law that required hospitals to have discharge protocols for overdose. And now those protocols have to include naloxone. So that's the change. Okay, in summary, homeless services organizations, opioid treatment programs, intensive outpatient programs, detention centers, parole and probation, and hospitals, all required to offer naloxone to people at risk of overdose. EMS can do it. This supports their ability to participate in leave behind. It's not a mandate for them, but they can do it now. We're writing regulations for this, and we'll keep purchasing the naloxone for its implementation. Businesses are protected from causes of action or civil courts, or protected from being sued. And this got signed by the governor of Maryland on July 1st of 2022. So it's in motion. We're working on it, and doing a lot of outreach. I've given this presentation a million times, and hope to do more to these providers in Maryland. We're writing up some sample policies and procedures for them, thinking about what technical support they might need. And then we're also staffing up, because this is going to be a tremendous effort. I was very grateful for the opportunity to share it with you all. I often connect with other states, and I'm really proud of this work that Maryland is doing. And I think it puts Maryland on the forefront in terms of naloxone access in our state. And so very much appreciate the chance to, just brag about it a little bit to another state, but also to learn about what you're doing and see how Maryland can be of support. So thanks again for having me, and I'll take any questions now if there's time.
Thank you so much, Ms. Russell. Any committee members with any questions at this time?
Yes.
Eric,
Chairman,
please proceed, Eric.
Thank you. Thank you for that presentation, Aaron. Sounds like you guys are doing some really great things with naloxone. I've been working for the last several years on the same thing in rural Nevada, and we've noticed stigma has really come down to the point where community members are really asking for naloxone in a way that they weren't before. And so we're still focusing on widening access to naloxone, but we're now moving also to fentanyl test strips. And it's interesting, it's kind of like the lessons and the tools that we had to use 5 years ago for community acceptance around naloxone, we're also now having to do around fentanyl test strips. And it's slowly opening. People are realizing it's a necessary tool. I'm wondering if Maryland is looking at adding fentanyl test strips as part of their strategy.
Yes, we've integrated test strips into our harm reduction work. A few years back, there was a law change that allowed, we had to do a legal change that removed the words testing and analyzing from our paraphernalia statute. And that was in 2017 or 2018. And so we did a push in 2018 was our big push to get programs to hand them out. We also conducted an evaluation of it in 2019 because people really wanted Maryland data on this. And so happy to share any of those, that more about that study. We did a very informal thing where we just wrote a survey up, and our harm reduction programs who were giving out naloxone were also offering test strips. And then when they saw the person again, they asked them to fill out the survey. And the survey showed that 90% of people who got a positive results on their when they screened their drugs and it was positive for fentanyl, 90% of them did something to change their behavior, whether that was anything from throwing the drug away to using less to just being motivated to ask for naloxone at their next harm reduction visit, things like that. And so that was very valuable and helpful for us to do to talk to people in Maryland about it and be able to, for people who were pushing back on it, to be able to tell them that we've surveyed Marylanders who are using this, and this is what we're seeing in our state.
Aaron, is there any, I'm sorry, Chairman, just one quick follow-up question. Is there any chance we could get a copy of that, do you have a report with that data?
Yeah, the report's in a PowerPoint presentation, and I'll as a follow-up, I'll certainly send that to you. Happy to share it.
Thank you so much.
Yeah, of course.
Thank you so much, Ms. Johnson.
Yeah, thank you, Chairman Dignate, and thank you so much, Aaron, for a wonderful presentation on the STOP Act and your work in Maryland. I had a quick question about the hospital section around naloxone distribution. Some hospitals that I'm aware of are open to distributing naloxone, but are requesting it come through a prescription at their pharmacy. And it sounds like the STOP Act will be handing out naloxone directly to patients through peers and through other work. And I was wondering if you could talk a little bit about, if that's the case, the implementation of that and why that's important, rather than through just perhaps a prescription route.
It's a great question. So I just had a meeting with like the Maryland Hospital Association this past week, and they were saying like, well, all hospitals are doing this. Like it's not an issue in hospitals. And I was like, well, writing the prescription and asking someone to go to a pharmacy is not the intent of this law. The law is meant to address the barriers that we know exist to getting naloxone. And I mean, anecdotally, I know this, but also there have been some published studies about how getting that prescription and having to go to a pharmacy, I mean, the majority of people don't follow through on it. We really need to like make it as easy as possible and put it in their hands as we're talking to them about it and before they walk out the door. So some hospitals have navigated that by doing a bedside delivery. So I'll say one is just like the logistical barrier of someone actually going to the pharmacy and following through with picking up the prescription. But then there's when you pick up a prescription, it gets put in your name, it gets billed through your insurance. The concerns about life insurance policies identifying naloxone on a prescription history are very real, and so people are hesitant to do that. Then you encounter another barrier of copays. So in Maryland, we know naloxone's covered by all insurance providers, but copays can vary widely. And even a $2 copay can be a challenge for some people, especially when we're talking about people most vulnerable to overdose who may have Medicaid, and that copay can be $1. Or people who are, you all understand that point. So it's all of the above. It's the convenience, the inconvenience of going to the pharmacy, the identification of it on your prescription history, and then there's the potential cost barrier of the copay. So So it's really a bit of a paradigm shift for some hospitals who felt that they were checking this box by offering a prescription for naloxone. And we're having to restart some of those conversations and explain that if the bedside delivery program isn't an option, or there's the insurance or cost barriers, even with that model, having naloxone on site can solve all those problems and just make it a lot easier. So yeah, it'll be a bit to navigate, but and it's not written in the language of the law. This is something we're trying to accomplish in regulations. The language of the law, as I showed you, it's very simple. It's just that shall require the offering of naloxone free of charge to a patient who received treatment. And so if they offer a prescription, I guess that's technically offering it. But in regulations, we're trying to make it more specific that they're going to offer the physical naloxone to them on site. And yeah, that'll be definitely some, it'll be, what's the word? Uptake. We'll need to see some uptake of that among hospitals, even where they're already meeting the intent.
Thank you so much.
Thank you.
Thank you so much. Any other questions before we move on? I don't see any. So thank you so much, Ms. Russell. Always a pleasure to connect with Maryland folks. It's where I went to school. So, and
oh, great.
MDH is always leading the way. So thank you so much.
Thank you for that. It's great to be here. Thank you.
Let's go ahead and move on to our next agenda item, the subcommittee recommendations and discussion of our top 5 priorities. So I want to go ahead and use this moment to perhaps share and review the weighing process that we have administered through the recommendations that we have received. So I'm going to go ahead and turn it over to Emma, who can describe more and some of the different color codings that we have. And then after that, we can have further discussion. So please proceed, Emma.
Great, thank you. So as y'all might recall, after the July Prevention Subcommittee meeting, we requested additional recommendations from subcommittee members. We did receive 5 new recommendations, which we will review shortly. However, due to open meeting law, those could not be included in the initial round of prioritization. So the slides you're going to see shortly don't include those new recommendations and the prioritization. So 2 of the 5 were from Ms. Nadler. Unfortunately, she wasn't able to make it today, so I can just quickly read the new recommendations that she submitted. So 1 was to provide appropriate primary prevention education and programming in K-12 schools. And then another one, so you might recognize this I believe came out of the July meeting, which was to establish a fund within DHHS to set aside funding for small grants to programs geared towards substance use prevention and education, grassroots. And then she talked about how grassroots movements in our state who have either suffered a loss or in recovery, and they're most knowledgeable and up to date on what's happening and what's working and what's not working. So the recommendation is basically for a fund for small grants. And then I will turn it over to Ms. Johnson, who submitted 3 recommendations of her own.
Yeah, wonderful. Thank you so much, Ms. Rodriguez, and the opportunity to share a little bit more about these additional recommendations. Do I need to be recognized by the chair? Sorry, Jessica Johnson for the record. I'm still learning Robert's rules all the time. My first recommendation was to make for the SURG to make a recommendation to DHHS to utilize opioid settlement dollars to designate a baseline of naloxone kits for the next 10 years across Nevada. This could be based on the state naloxone saturation plan. This would be an important recommendation because it creates a stable and sustainable source of naloxone throughout the state. And could free up the grant dollars that are currently paying for things like naloxone to do other types of programming and projects. This would not be prohibitive if a particular grant or a particular program wanted to source naloxone for a specialty project, but I think looking forward and how we look to combat the overdose epidemic, having a sustainable, stable source of naloxone is going to be imperative. For us to think about. The second recommendation is based on a law out of California called Tyler's Law, I think was the working title for that. And this would make a recommendation to the legislature on behalf of the SURG to include fentanyl if a urine drug screen was ordered in an acute care hospital, to include fentanyl if the person is being treated at the hospital. So right now, hospitals, to my understanding, are screening for 5 types of substances, and this would additionally include fentanyl in that screening for diagnosing a patient condition. And then the third one, we just heard a presentation from Ms. Russell regarding Maryland STOP Act. So this would be a recommendation to the legislature to create the Nevada STOP Act modeled on this type of legislation, compelling the entities which Ms. Russell, I thought, outlined really well in her presentation to distribute naloxone. I think there's an opportunity to do some more very grassroots and work with individuals and entities that are serving people who are experiencing overdose in the time that they are. We know that there are a lot of fantastic service providers across the state that are working to give out naloxone and dispense naloxone. And our data are also showing that we're not reaching people soon enough, and we're not getting that into the hands of folks that can save lives based on the increased number of overdoses. Thank you.
All right, and then if I may proceed, Chair, I can just review the waiting process. So prior to this meeting, prevention subcommittee members were asked to prioritize their top 5 recommendations that had been submitted before the July meeting. So again, it doesn't include the ones that Jessica and I just read. We received prioritizations from 4 out of the 5 subcommittee members, and then the recommendations were weighted. So if the subcommittee member picked 1 as their first choice, that received 50 points. If it was, I won't go into it, but basically they're weighted 1 through 5. And so on the following slides, and also posted on the SURG website, if you want to take a look there, you can see how if multiple subcommittee members ranked the same recommendation, we highlighted that in blue, and it has a corresponding cumulative score. So if one person ranked a particular recommendation their first choice, and another person ranked it their second, then we added that up for a cumulative score. And I believe the plan is to reprioritize, so this isn't final, it's just to get an initial sense of where the subcommittees stand on with those recommendations. So this was the top ranked. So you can see one subcommittee member ranked it their first choice and one ranked it their second. And so that was to continue to invest in standing up community health workers and peer recovery specialists throughout Nevada. This one, when I was compiling these recommendations along with Laura Hale, who's another subcommittee staff, we noticed that these recommendations all were very similar, and so wanted to see if perhaps the subcommittee wanted to compile and synthesize these into one recommendation. So it's, one is around co-locating integrated supports with mental health and SUD professionals in schools. Another is on providing certified prevention specialists in Nevada schools, investing in a multidisciplinary cross-department school-based behavioral health team, and then increasing school-based health qualified mental health professional workforce. So again, really around behavioral health professionals in schools. So that perhaps is something that the subcommittee might be interested in synthesizing towards the end of this meeting, and then we could reprioritize after with these new recommendations. And then this recommendation also had a high cumulative score of 80. So 2 subcommittee members picked this. One was first ranking, one was third. So it's to contract with a company that specializes in data collection, evaluation, analysis, and assessment, and provide consultation to entities across Nevada to help improve internal local data collection systems and create a comprehensive statewide data sharing system that includes all state dashboards and public data. These all were a rank of 1, but didn't have other subcommittee members included in their top 5. So 1 was to provide educational opportunities to increase competency of clinicians providing adolescent care. And then another one was on utilizing harm reduction strategies. These were some of the other subcommittee members' second rank. So I will just note, so this one on adverse child experience on ACEs, it pretty much includes 2 recommendations. So we also wanted to see if that particular subcommittee member who ranked this, if they want to pull that out, so we could include that in the new prioritization as just 1 recommendation, since we do need to not compile multiple recommendations into 1. Another one was to enable educators to build capacity to address psychological first aid for students. And then another one was expansion of Project Aware statewide. This one had a cumulative score of 30. So 2 subcommittee members ranked it. They were towards the bottom of their top 5 though. So that was to establish a bridge MAT program in emergency departments. Another one on building and strengthening comprehensive fast and most teams statewide. Another rank of 3 was to expand Medicaid billing opportunities and allow blended and braided funding to facilitate services for system involved in at-risk youth. And then towards the bottom of the rankings was to promote telehealth for MAT. Another one was to encourage greater implementation of SBIRT across primary care settings. And then finally, the last was to ensure the use of housing first initiatives to decrease drug-related harms. So I believe that the plan is to, in the September meeting, pick the subcommittee needs to decide what are the top 5 to 7 recommendations that they will bring forward to the October full SURG meeting. So again, this is really just to provide everybody with a sense of what that initial prioritization was like. And I can just kind of go over the rest of the process, and then I'll let Senator Doñate let me know how he wants to handle the rest of the meeting today. But going forward, so after this meeting, we will send out a new spreadsheet to all subcommittee members that includes the new recommendations so that you all can reprioritize. And then we'll come back to the next subcommittee meeting on September 15th, and we'll review that new prioritization similar to what we just did. And then come to a consensus on what the top 5 to 7 recommendations should be to bring to the full SURG October meeting. So, Mr. Chair, I will turn it back to you for how you want to handle synthesizing recommendations or any discussion you want to have.
Thank you. Can you go back to the slides with the color coding first? I think those probably can start with those recommendations.
So this is the top one.
Let's start with that one first. Okay. And can you scroll down to the next slide? Perfect. Okay. So I would like to hear feedback from the members, considering that a lot of these are, for these particularly our school-based programs, we can determine that one of the policy recommendations that we're going to submit are the school-based ones, since it looks like everyone jointly recommended those. So we can put all of these together into one. If there's any comments or concerns, Jessica?
Thank you, Chair. I would love the opportunity to dialogue out exactly what this looks like. I do agree that the school-based recommendations are here together. I do see a lot of different specialties sort of being highlighted between the prevention specialists and mental health professional workforce. And I know there's already some mental health professional workforce legislation in place. So would want this committee to consider being, I guess, cautious in our language and how this gets put together to really address the recommendation and make sure that it fits within the bylaws. Thanks.
Great. Senator Gansert?
Thank you. You know, we had Christy McGill online, and she had talked about that MTSS platform too, and I think that fits in this category, but I don't see it listed, and maybe because we had so many choices, that was part of the issue. So I want to make sure that we kind of throw that platform in here too, if that's possible.
Yes, ma'am. And Eric?
Yeah, thank you, Senator. So I'm involved in several conversations across the state and trying to increase capacity for communities writ large, for people to have access to all sorts of resources so that they can not only survive, but thrive. And a lot of the focus these days is on intervening earlier in the food chain, if you will. So starting with schools, making the schools a really robust place for students and families, because a lot of parents interact, to engage with the resources needed to be successful. And so, yes, Christy McGill is doing fantastic work as well. And this is in line with that. What I see through these 4 or 5 recommendations is basically, if we decided to go forward with something, saying we need to invest in a robust platform of resources for children and families to access at the school level, from prevention through intervention. And we can include ACEs in here as well, because ACEs doesn't have to sort of be off by itself. I think a robust program would include education about how to address ACEs, the impact of ACEs, and then how to mitigate that impact.
Thank you so much, sir. Would you be able to start from the comments from Senator Gansert, Jessica, and Eric? Can we start to put something together along those lines?
Yes, I'm sorry again, I'm working off my laptop today. I can stop sharing my screen with the PowerPoint and pull up a Word document. Would that be helpful? Are you all able to pull up the PowerPoint on your own screen, or it should be on that SURG website. Let me go ahead and do that, and then I can kind of type the recommendations. Just give me one moment.
That's fine. I think with the remainder time that we'll have, we'll probably the only other policy discussion we'll have is community health workers. And if we want to talk about Ms. Nadler's before next meeting, that could also be something. Or just Ms. Johnson's recommendations as well. We can talk about that before. But I think you're good to move over to.
Okay, so did somebody want to take an initial try at what that recommendation would be around behavioral health?
Ms. Johnson?
I just, thank you, Chair. Wanted to say, I thought what Eric said was really fantastic. The robust approach to a system. Eric, do you want or Chair, I would love for Eric to maybe kind of come up with that main piece, and then we can sort of bullet point under, if that's all right. Don't want to put you on the spot, Eric.
Yeah, fortunately, I think this meeting's being recorded, so we can always go back, but it's always hard when you're shooting off the hip. Yeah, I mean, basically, I'll try to capture that again. The idea, I think, is that communities are recognizing we need to invest in having a robust platform of services available to school children and their families. I mean, really, that's schools are one of the most, maybe the number one place for those families to be connected to pro-social kinds of resources and the kids themselves. So everything from education to early intervention to even counseling services, which is where Christy's team comes in, trying to get social workers into the schools and making sure we're taking care of that, addressing and mitigating ACEs, providing resources for families to connect, overcoming some of the social isolation that we've seen through the pandemic and the harm from that. But okay, I think hopefully you can capture something from that, Emma.
Okay, great. Apologize. I just was trying to get this down because I believe, and Rosalie, I know you're on, please correct me if I'm wrong, but I believe in order to prioritize this, we need to get the recommendation out in the public now. I don't think we'd be able to come up with it after and then have people prioritize. Is that correct, Rosalie?
Sorry, I needed to unmute myself there. I would prefer as much of it be part of the public as possible. The main worry I had is to the extent that there's any back and forth between members in between meetings is what I don't like. If you want to kind of set out that members are going to give some bit of feedback to a staff member who compiles it for a later meeting, you can. But you definitely can have a lot more full and frank discussion during the meeting. During the meeting is when that discussion needs to occur.
Okay. Thank you so much. So does it work then if I kind of take this, pull in stuff from the discussion that we just had, and then maybe I can either work with Eric or with Senator Doñate and then include that on the prioritization spreadsheet?
That sounds good. Yes.
Okay.
Cool.
Yep. I think if we can start to merge some of the ones that we just talked about based on our earlier conversation. Okay. I think that one should settle a lot of the school-based programs that we were trying to modify, at least in some respect, or help invest in. Okay. Any other comments before we move on from these four? I don't see any. Okay. Let's move back to the community health worker one. Lovely. Okay. So with this one, I know that in general, we always need more support for community health workers. I think in the joint interim HHS committee, we talked about the certification process of it, but perhaps Eric, do you want to talk? I know this is
Sure.
An area that you're probably more fairly interested in.
Yeah, and actually this dovetails with the last priority, and that if we have a really robust team of professionals, it's going, the bulk of those workers will likely be community health workers and peer recovery specialists with lived experience who will be helping to man the team, if you will, so that we have people who are out in the community connecting families and students to these resources that are available, because we just don't have enough and we can't commit enough because we're decades behind having enough capacity in mental health professionals or substance abuse professionals as we've traditionally thought about them. So we have to think outside the box. the nice thing about community health workers and peer recovery specialists is they're oftentimes from the communities that they're serving, that they live in and that they're serving. And so they already have some earned authority because they already have those relationships. And they also have a cultural fluency that folks from outside the area don't tend to have. So those are some strengths. They come in, they see that the community is also from a strengths-based perspective, which helps. And so they really are sort of the worker bees. I liken it to a construction project where you have one architect and 100 workers. The community health workers and peer recovery specialists are like those community building workers. And so it makes sense to me that this would be at the top, and then they have the school based interventions that we just talked about. It's number 2. That's a really powerful 1-2 punch.
Okay, so with this particular proposal, I'm trying to think back. So we, in the joint interim HHS committee, we talked about making revisions as to the supervision of community health workers, but there's still that missing piece, which is how do you incentivize and make sure that we actually are building out the structure or the infrastructure of it. So is there a conversation that we need to have as to maybe looking at the reimbursement, or maybe providing funding to providers to onboard or to start the process of hiring community health workers? Or I guess that's
Okay.
the question that I would have.
I appreciate, thank you for the clarification. So I know there are several organizations who are working on helping people become more familiar and comfortable utilizing community health workers. The one that comes to mind is the Nevada Community Health Worker Association that has a federal grant to place community health workers throughout the state. I also know there's conversations involved with Medicaid to expand reimbursability to include community health workers connected or associated with behavioral health providers, not just hospitals. And so that would help to expand the sustainability of how and what community health workers could be reimbursed for. So I know there's conversations already around that, and I expect that will happen. There seems to be an appetite for that already. So I think we will see more sustainability. And I think partly, I know a lot of Jay, who is the director of the association, a lot of his work is simply translating sort of what's already been done for the benefit of potential employers and how they can utilize community health workers in a way that really makes having the position sustainable and value added. A lot of it's still education.
Ms. Johnson?
Yeah, thank you, Chair Duniate. This is more of a sort of question in the discussion of this particular recommendation. I believe community health workers are also reimbursable by Medicaid. I'm curious, on the second slide, we have prevention specialists in the school system. And I'm wondering if the committee, provide certified prevention specialists in the schools. And I'm wondering if the committee wants to include the incentive process as part 1. Are they peer certifications in that regard, or and then the implementation of them through the school-based recommendation as additional support or and prevention, substance use prevention experts. So that was, I think, the question that came to mind for me, and wanted to just bring that up for discussion.
Senator, can I ask a clarifying question?
Sure.
Ms. Johnson?
Sure. Yeah,
Okay.
please proceed.
So Jessica, are you saying that, so in addition to community health workers and peer recovery specialists, we'd also list prevention specialists? So we'd have 3 instead of 2 on that next slide? On that one?
Yeah, that I guess is sort of the question of the committee. So in thinking about that as a recommendation specifically to schools for certified prevention specialists to assist with the implementation of the prevention curriculum. I don't know that there's been the same investment in that particular certification to date as there has been for CHWs and peer recovery support specialists, but it is, I happen to hold that certification, so happy to answer any questions about that. But just thinking through the pieces to that they may also fit in here, but wanted to bring that up for discussion with the group.
Senator, may I?
Please proceed.
So I know the prevention coalitions would love for us to highlight the value of certified prevention specialists, because that's primarily the work that they do, and it's oftentimes not seen and recognized, and it's super valuable. I mean, it's the building blocks of a really strong community is basically the work that, Jessica, you've done in that role, and these coalitions are as well. So in my mind, that I am really intrigued and excited by the idea of adding them to this potential recommendation. If we decided to somehow elevate or lend our voice to saying, yes, community health workers are important, peer recovery specialists are important, so are certified prevention specialists.
If that's all right with you all, then I can make sure to add that in to the spreadsheet when we send that out again.
Yes, please.
Yep.
Okay. Any other comments on CHWs or peer recovery specialists? No. All right, let's continue forward. Okay. So, okay. So with this one particular, I think a common structure. So really quickly, because I could pivot it back to any questions or comments on this. I think a common structure or fault that we have when we apply for grants is that we don't have the data to support why we need the grant. I think that's one of the reasons why I ranked this one pretty high, because it kind of supports the ongoing support that we need to make our program sustainable. And I don't know if this fits with any other proposals that we can consider, or if this is a standalone one, or if there's things that we can add to it, but I'd love to have any feedback from any of the committee members. Senator Ganser.
I agree. We need to be able to collect the data so that we know where we are when we're improving, and hot spots and things that we need to do. So I think this is pretty fundamental to any work we do.
Thank you. I think Ms. Hale wanted to say something.
Yes, thank you, Chairman Donate. I just wanted to let members know that the subcommittee for response just met last week, and one of their priority areas overlap with some of yours. So you can imagine data sharing is something that does cut across multiple of our subcommittees. So just to be aware that that's in the mix, and maybe you've got this meeting and then you've got another meeting ahead of the October meeting of the SURG group, where all the subcommittees will bring in their top recommendations to then sort through. So that's one where there was overlap. Also, MAT treatment is another area that the response committee was very focused on. And then there was one other item that came up. Let's see. In terms of compiling multiple recommendations into one, we did flag the one that Emma referenced earlier, but then in the discussion with the response subcommittee last week, they did talk about some omnibus bill drafts, for example, where you might combine multiple things like that. And so I know Dr. Kearns is on this call as well. I don't know if she's able to weigh in, but there was discussion around that and whether or not they could put something forward under the Attorney General's office as kind of an omnibus. So I don't want people to think that that is absolutely prohibited. There are ways around it, but it does make for a more complex recommendation. So I just wanted to let everybody know what had come up in the other subcommittee that might have bearing on your decision process. Thank you so much.
Thank you so much, Ms. Hale. If that's the scenario, then I think we could table this one for our next meeting. And if no one else has taken it on, then we'll take it on. But Ms. Johnson, did you have any other comments?
Yes, thank you, Chair. I think I have concern about the language in this of contract with the company. I don't know if we would want to be that specific. I do think that this speaks to the need for some sort of a backbone agency that can help support data analysis, collection, assessment, and consultation, not just, and that sort of coordinated effort across the board. Thank you.
Agreed.
Would you want me to reword that to say, instead of contract with the company, it could say support standing up a backbone agency to specialize? Okay. And then it sounds like, since that one, I can also make a note then, I guess, in the spreadsheet that the response subcommittee is also considering something like this.
Yeah, so if you can keep, if the team can keep track of it as it's going to other committees, if other committees don't include that as a final recommendations, then we will definitely consider that. That way, we're not duplicating efforts and we're not ignoring other policies. Okay, since Ms. Nadler's not here, I don't know if Eric jumped off already, but let's go ahead and talk about Ms. Johnson's proposal, since Ms. Johnson is here, and we can talk more, especially considering the discussion that we had earlier today. There you go. Ms. Johnson, did you want to have any other discussion outside of what you presented earlier?
Not in particular. I do recognize that some of these are perhaps a little bit more downstream than a traditional prevention recommendation. As I read the bylaws and the charge of this committee, they did seem to fit, but happy to open this for discussion, and if the committee members have any additional questions with regard to these, happy to answer them.
The main question I had is probably for number 2. So the recommendation would be, so you said that there's 5 categories right now of what is collected during the drug screenings, so add an additional one. Do we know if there's pushback in other states as the cost of that, of getting those supplies, or would this policy proposal allocate funds to allow hospitals to start making those adjustments?
There is a small fiscal note according to California. My understanding is that I believe the cost was less than $1 per test. So, and this would only be in the case when a drug screen is already requested. So I think I provided that links to that within the spreadsheet as well. So that hopefully answers that.
Yep, it does. Eric, did you want to have a comment?
Just a really quick process question for you or anybody on the committee, because I haven't been able to be a part of some of the previous meetings. First of all, excellent recommendations, Jessica. I really like the first one of establishing a baseline for naloxone saturation. Having said that, did we make a decision about those that are sort of more harm reduction versus maybe prevention? And then were we still going to rate those and maybe elevate those differently than sort of other prevention kinds of priorities?
Yes. So what we decided is, if we choose to collate these recommendations from Ms. Johnson, as we're building our policy priorities, we will separate them from the other one. And if it's included all together, then we'll include it all together. And if not, then we'll reach that point. But since today's discussion was on harm reduction, that's why I wanted to mention this.
Okay, and then I've got to go. I'm sorry, guys. I have another meeting. Great discussion. I look forward to the next one.
You're good. Thank you so much. Ms. Johnson, did you have any other comments?
Yeah, I just, on the comment of harm reduction priorities, I will share, even as someone who's worked in this field for a long time, as I read through these recommendations, I thought that they could be interpreted in many different ways throughout the spectrum. So some of them might be considered secondary prevention based on the audience that it was for. Some of them might be considered harm reduction or tertiary prevention. So I didn't know if there was an opportunity to work with staff to this committee to designate the ones that were considered harm reduction. I included them in my initial recommendations because I did think they were really important. And we did have a lot of recommendations to choose from. So I just wanted to elevate that. I don't want to add obviously additional work, but I do want to ensure that we're fulfilling our obligation as committee members and ensuring that we're considering these as the direction of the committee. Thank you.
Thank you, ma'am. Unless there's any other comments, I think Emma, you can proceed to put these recommendations on our policy the one on the spread on the document that you were.
Okay, great. Thank you. I will do that. And could I just make a comment about the harm reduction?
Sure.
So yeah, as Jessica said, it can be tough to determine what's harm reduction, what's tertiary prevention. So I think that some of the other in discussions, and Dr. Kearns and Ms. Hale can likely speak to this with more knowledge than I can. I think it's going to likely require discussion among the full SURG for how to handle the harm reduction recommendations, and in the new year, how that will work within the prevention subcommittees. So I think how it's been working is how the best we can do so far. And when we meet in October, we can have a discussion with the full SURG about how to handle all of that. Senator, did you want me to go back to Ms. Nadler's recommendations?
Sure, I would like to. We can talk about that briefly before. Okay, lovely. Great. I think this will probably be the last thing that we talk about before we move on to any comments on subject matter experts, and then obviously closing for public comment. Okay, so provide appropriate primary prevention education and programming in K-12 schools, and then establish a fund with the Department of HHS. So my initial response to this, and I would love feedback on this. Okay, number one, I think my general sense of primary prevention in schools, at least from my own personal experience, not going through that experience not too long ago, I think that in some circumstances it's going to need some sort of investment to reform our health education curriculums across the state to be more up to date and evidence-based. It's going to cost funds to train educators who teach health education in schools. It's going to cost funds to teach teachers, to instruct teachers or to train them on the new services that we're investing in the school-based programs that we just discussed. It's going to require the same amount of work for administrators. It's going to be a big burden to take this on. And so I would love to hear feedback as to if we want to rewrite this in general, to be more encompassing of onboarding evidence-based curriculums. But Ms. Johnson, I think you can proceed with your comment or question.
Great, thank you so much, Chair. I am in agreement that this would be a broad investment, and I'm wondering how this might fit under the omnibus school-based recommendation priority that was discussed earlier in this meeting. In particular, if this recommendation was about adhering to evidence-based prevention guidelines outlined in the CDC, I believe Senator Duniate, we discussed that. Your points about those health education recommendations from CDC were discussed in our July meeting. And so I'm wondering if this primary prevention education recommendation could be rewritten to be aligned with best practices or aligned with CDC recommendations as they're implemented. So if amended on this particular recommendation to be included with sort of the more omnibus school-based recommendation, I would be in favor of that with those modifications. And for recommendation number 2, I'm not in favor of moving that one forward at this time. Thank you.
Thank you so much. Ms. Senator Gansner, did you want to say anything?
No, I'm fine. Thanks.
Great. Before we make any decision as to whether the second one carries forward, I would like Ms. Nadler and for Eric to be here for that conversation. But I do think that we can begin to reword the first one to be more encompassing in general. Senator Gansner.
Senator, yeah, actually, I do think we should move the second one forward. I think it's a small pool of funds. Didn't realize we were ruling things out. I thought we were revising the list and moving forward.
No, we're gonna carry it for the next meeting. So we're not. That's essentially what I'm saying. I think before we decide to rule anything out, we should have a full discussion with all the committee members present for the next. So we'll table that for the September one. But for the first one, I think we clarified just a little bit, tweak in, moving into those school-based proposals that we discussed earlier. I think that would be a good decision. Okay. Any other comments on anything we've discussed? I don't see any. Okay. I'll go ahead and close this agenda item now, and we'll move on to the next one, which is to consider as subject matter experts for future meetings. I'll allow this moment in time if there's anything that we'd like to add based on circumstances. Of course, this meeting was shorter just because we slated more presenters, but they'll be moved on to the September meeting. So just expect the September one to have more presenters at it.
Yeah, if I could just add something, Chair. So we were going to have the Jamie Ross with the Prevention Coalitions at the original August meeting that was rescheduled. She was not able to make it today. So she said that she could be there at the September 15th meeting. So I just wanted to clarify that.
Thank you so much, Ms. Johnson.
Yes, in terms of additional subject matter experts, perhaps Chair Dunyate, you could suggest someone from the interim finance committee. I apologize, I missed the name earlier, that presented on the expansion for community health workers in sort of the systems-based approach, given that that was ranked as a high priority for the committee. I don't know if there would be someone from that presentation, or if there's a presentation the committee could watch in advance that would that's already publicly available that would be beneficial. Thank you.
Okay, thank you so much. I'll tag that responsibility to, I'm going to try to figure out.
Yes, I can certainly look into that. And if there's already a recorded presentation to the IFC or IHC, I could perhaps get that posted on the SURG website and distributed to the members. So you could perhaps watch that ahead of the next meeting. Or we could have them come as a presenter if that works.
Great, thank you. Any other comments? Seeing none, I'll go ahead and close this agenda item and move on to public comment. Once again, public comment is limited to 3 minutes per person. Members of the public may comment at any matter that is not specifically included on the agenda at this time. Of course, we're not going to take any action today raised on any matters that get raised. So let's go ahead and proceed. Emma, is there anyone that would like to provide public comment this time?
I do. I see a Miss Rhonda Fairchild with her hand raised.
Ms. Fairchild, please proceed.
My name is, can you guys hear me? My name is Rhonda Fairchild for the record. I'm just parking my car, so I want to make sure I'm completely
Please
parked.
proceed.
I just wanted to say thank you. And I was at the Southern Nevada Misuse Overdose Prevention Summit a couple weeks ago, and I heard a really good presentation on prevention for kids that are not yet using. And it really opened, I've been in this field for a really long time, and it really opened my mind to the differences of presenting drug awareness to a child who's never used and a child who has already used or is currently using or has use in the home. So I hope that this committee takes into consideration that it's a different dynamic in prevention. Are we preventing use or are we preventing death? Like, what is our prevention tactic? And I think that's it. Thank you so much for allowing me to speak.
Thank you so much for your comment. Looks like Ms. Johnson, public comment, please proceed.
Yeah, thank you. Jessica Johnson for the record. I just wanted to recognize that today is International Overdose Awareness Day, a time to remember and a time to act to address overdoses in our community. If anyone on this call is located in Southern Nevada, there will be in-person and online remembrance at the Chuck Minker Sports Complex from 5 p.m. to 7:30 p.m. today. So I am hopeful that if folks can attend, that they would be able to come. There will be a lot of services for individuals across the community, a lot of great community partner representation, some food available, and to hear some testimony from individuals with lived experience in our community. Thank you.
Thank you so much, Ms. Johnson. Anyone else that would like to provide public comment at this time?
I do not see anybody, Senator.
Great, thank you so much. Thank you all for joining us today. Looking forward to hearing more recommendations from the public and hopefully better discussions for our next meeting in September. I will go ahead and now adjourn this meeting. So thank you so much for all for attending and have a good rest of your day.